Hello.
Yeah, good evening.
Hi. Good evening. I'm Rashmi Basi. I am the coordinator for the meeting today. We have with us Dr. Kaushik Bhojani, a renowned rheumatologist from Mumbai. He is HOD at Fortis, Mumbai. Dr. Bhojani has a vast experience of 25 plus years in the field of rheumatology. A doctor par excellence, his experience lies in treating autoimmune conditions like scleroderma, lupus, ankylosing spondylitis, and much more. After his D.Ed.B. from Hinduja National Hospital, he trained under one of the pioneers of the rheumatologists, Dr. V.R. Joshi. He ran a very successful private practice till he joined Fortis last year. Dr. Kaushik is one of those rare doctors who is a tick in the box in every box. Empathy, patience, patient welfare, you name it, and he is there. He is, his detailing, his persuasion till he finds answers, and his personal attention. I can just go on and on, but then we rather hear from the master. Welcome and good evening, Dr. Kaushik Bhojani.
My God, the amount of praises you gave, Rashmi. Good evening and thank you very much. That was much more than what I deserve. Hello, everybody. My name is Kaushik Bhojani, and Rashmi has already given you my introduction. Yes, Rashmi.
Uh, yes. So, doctor, it is generally observed that the first symptoms are on the skin, and generally the patient goes to a dermatologist. How do we diagnose this disease?
So, in scleroderma is the original name for this disease, though it is now actually called systemic sclerosis, but we'll go to that later. Currently, the question is about how to diagnose it. So, the important part is you get darkening and thickening of the skin. The skin starts feeling stiff. In the earlier stages of the disease, you might have a little swelling on the body. You can make out that your body feels swollen and the body feels stiff. Some people may comment that your face is looking a little swollen. Initially, you may not get directly, you may not get any darkening of the skin. You might land up having some amount of, just a mild redness, like a flushed skin, like a blush skin. But more importantly, when that is associated with cold fingers, cold toes, excessive sensitivity to cold. Your fingers turn blue in the AC. If you touch the fridge and you want to open something, you find it difficult. Sometimes the fingers pain when you're exposed to cold. Then you know something is wrong because now the blood circulation is an issue. The skin is feeling a little stiff. So the early stages, this is what would the patient would feel. There would be some amount of fatigue, some body ache, skin feeling tight and swollen, fingers feeling cold and blue. And in addition to that, you sometimes land up getting increased acidity. Now, the moment you've eaten something, it's not necessary that the food was spicy, but even if your food is a little delayed, you might land up feeling a lot of reflux, a lot of sour burps that are coming on at night. And that would be an additional sign that I need to get investigated because two, three systems in my body are creating a problem. That's how you would actually pursue it. Very occasionally would you get an immediate lung affection with a lot of shortness of breath or dry cough. That's very occasional. Most of the times the symptoms start with the skin, the acidity, the cold fingers.
So, would it be right for me to, at this point, consult a dermatologist?
If the natural tendency, most people don't even know who a rheumatologist is. So, for example, even today across the country, if you have joint pains or bone pains, you go to an orthopedic surgeon. Similarly, the moment you get a skin issue, you'll end up going to a dermatologist. So, I'm not surprised that people will go, and the mind shift is difficult to change immediately. However, we must also take into consideration that not every city has a rheumatologist yet in the country. We have about 1,500 rheumatologists in the entire country of this size. And so a lot of the tier B, tier 2, tier 3 cities don't even know what a rheumatologist is. And hence, expecting a patient to no, no, find a rheumatologist, travel across the globe and do that, may not be practical. It's not even advisable to try and do that. Going to a dermatologist is possibly a very natural reflex. But it's up to the dermatologist to realize thereafter that this is something more than the skin, and you shouldn't be just giving some creams and some medications and so on. There you need to go further because the fingers are cold and the facial opening, the pigmentation is uniform. It's not like a rash on the face or something that you treat. You find that the skin is uniformly getting darkened or uniformly getting red, or it's puffy. The dermatologist would possibly be the first person to really pinpoint that there is something which is going on inside the body.
Absolutely. A very, very, a very well put up answer. Doctor, we often hear the patients complaining that, oh, my doctor is calling me too often, or my tests are being done too often. Why is, these tests so important that we need to do it periodically? And why do we need to see a doctor in every 3 to 4 months?
See, as I said in the very first statement, that the actual name of the disease is systemic sclerosis. This is not scleroderma. It's not a skin disease. It's a disease related to your body's immune system. It affects the lungs apart from the skin. Skin is the starting point. The skin can become very tight bound. It can cause joint pains. It can cause a lot of flexion contractures. You can land up getting something which looks like an arthritis, but the important part is what happens inside. And so the way the skin becomes tight, the muscles become tight, the tendons become tight. Similarly, what happens is the lungs become stiff. The food pipe has become loose. Now there's acid which is throwing up every time you sleep at night. There are drops of acid, micro drops, which are seeping down your throat and coming down the lung. So the lung tends to get affected. In addition to that, what happens is that the kidneys can get fired in certain cases of systemic sclerosis, and that can, in fact, be a threat to life. We won't talk about the rare causes, but it can happen that the scleroderma causes stiffness in around the heart as well. But most importantly, what happens to practically every patient across is the fact that you will end up getting ulcers on the fingertips on cold exposure if you haven't attended to that. And now the breathlessness with the stiff lung, remember, it can cause a back pressure on the heart. And so most people understand heart patients and heart attacks in terms of having reduced blood circulation to the heart, and so you do angioplasty and so on and so forth. But what people do not know is that this cause, the heart has two sides, right? The left side and the right side. All of us are always paying attention, going to the cardiologist for the heart problems which they call. What they don't realize is that the opposite side of the heart, which receives the impure blood from the lungs, that gets affected because the lungs are stiff. So if you remember the old time water filter, there used to be पुराने जमाने का एक water filter था. उस water filter में ऊपर हम पानी डाल देते थे, उसमें candles होती थी, और candles होने में से पानी filter होके गंद ऊपर रह जाता था. Clean water used to come down. Now imagine when the candle got congested and coated with all the mud, now the water remains up and it doesn't come down. And that's what happens. The pressure is built up. The top of the barrel is completely stiff, but there's nothing coming down. That's what happens in scleroderma as well. The lungs are your filters, they are your candles. Impure blood comes there, does not get filtered. So now you have less oxygen. It is not getting filtered and going to the opposite side of the heart. So your BP keeps falling because the clean blood is not coming on the opposite side. So now you get a similar kind of a heart failure like a heart patient, but the difference is it's happening because of the lungs. So when you correlate all of this and you realize that we need to look after your fingers, we need to know whether your lungs are functioning fine, we need to know whether the pressure is building up on your heart, we need to know whether the acid is building up and coming up your throat and spoiling your lungs further. Unless we look after all this, in the first 7 years of scleroderma, when it keeps increasing, it can make you miserable. And thereafter, the damage is already done. Once damage is done, it's not repairable. After that, you just face consequences of the damage. And hence, what you need to do is start treatment before the damage happens. And because of that, what you do is you will do a lung function test 6 monthly. You will make the patient walk rapidly for 6 minutes and measure his oxygen levels. It's called the 6 minute walk test. You do it every 3 monthly. You do a 2D echo, which is done 6 monthly, but you don't do the echo for the heart problem. You do the echo for the lung side of the heart, the right side of the heart, and that's called the pulmonary artery pressure. That's the artery which connects the lungs and the heart. Is the pressure building up there? If that's building up, that means the scleroderma is acting there. And of course, when you examine the patient, you have looked at whether the food pipe is getting more and more dilated. Then you need to worry about the pressures, whether the food is building up here. That part aside, these patients land up getting infections very often because the food is stale out there. It's lying in the food pipe. The stale food goes down very slowly from the intestine. And so bacteria build up in the intestine. Now, naturally, out of all this, patients are able to tolerate intermittent loose motion, sometimes constipation. They go to their GPs, they go to their physicians, they manage it until it reaches a stage where the food pipe is very badly affected. Then they come to a gastro. But if you consider the fact that the lung and the heart, which are important for your life, if they are getting affected, because of which your mobility is going to stop, your going out of the house is going to stop, you will get breathless after every few steps, and that means you are restricted to your bed, then that's a horrible life worth living. And post which also we land up going, eventually, if the lung gets totally damaged, on oxygen. Now, try and imagine that if the lung is damaged, the only thing you can do is a lung transplant. If the heart is affected, will you do a heart lung transplant? Is that really practical for every person? I'm not talking about the money, the cost will be huge, but that's not the discussion. After that, you are dependent on waiting for somebody else's. Imagine the sad part. You will hope on a transplant waiting list that some young person dies so that his lung and his heart comes to you so that you can live. Isn't that the irony of life? And then you are going to be having a low immunity all your life because the number of drugs that are required after a transplant are much higher than what you get when you're on the scleroderma treatment. So it is irritating for patients to do blood tests every time, to do PFT every time, to land up doing a CT scan every year. I understand all of that. But really, the other option, is it even worth thinking about? You want to stop any of this happening. Now, we do know that between 7 and 10 years of scleroderma, the disease plateaus and then stops increasing. Now, if you catch the patient fast enough and thereafter you keep the patient stable for about 7 to 10 years, then your chances are that the further damage will not happen. I have patients who have had scleroderma now for 25 years. They're socializing, they're doing everything. But of course, they have become so particular themselves that now they do more tests than I ask them to do. They've gotten so used to doing it that they come to me with a bundle of tests every 6 months and say, "Ye maine sab kara liya. Abhi aap dekh lo. Am I okay?" Now, those are the ones who have continued to enjoy their lives. So it gets irritating. Nobody likes to take medicines. Nobody likes to be constantly testing. Nobody likes to spend so much money, even if they have it. They think we would rather enjoy life rather than sirf dawaiyon or test pe paise kharcha karte raho. But really, the cost on the other side is not worth it. So there isn't much of an option. We need to have these tests to kill the progress of the disease, plateau it out so that it allows you to live a decent life thereafter.
Absolutely, doctor. I completely agree with you. Just going on the same track, doctor, nowadays we are hearing a lot about stem cell transplant, and a lot of doctors are claiming it cures you of scleroderma. What is your take on that?
So the word cure is such a ubiquitous word. Everybody uses it in different fashions. Doctors say we cure you. What they mean is that we will not allow the disease to go forward. Patients very rightly think that क्योर मतलब बीमारी चली गई अब मुझे जिंदगी में वापस आएगी नहीं आई एम सॉर्टेड आई डोंट नीड टू बी ऑन एनी मेडिकेशंस my disease is gone and somewhere in the middle are people like the diabetologists who say that we will control your diabetes but the patient turns around and thinks my diabetes needs to be cured so there's a level of dissatisfaction that happens मुझे तो बोला था मेरा शुगर चला जाएगा गया नहीं अभी तक मैं दवाई ले रही हूँ so you get all varieties of mental understanding of the word cure. So I will just touch on that word cure. What cure will do is not, the attempt is not to allow the further progress of the disease. What has already happened has happened. You will live with it. There is no choice. If you've already got blood circulation which is compromised on the fingers, you are not going to get fresh fingers there. You're not going to get fresh, the ulcers will not disappear. You will have those scars there, they will remain. If your fingers have become thin and if your teeth have become spoiled and if your mouth has become narrow, it will remain like that. People think cure matlab मैं पहले जैसी हो जाऊंगी. That will not happen. But yes, stem cell is being tried. It is tried for people where the disease is progressing so rapidly that it can become a threat to life. Now, when that happens, where the lung is getting damaged very quickly, the heart is getting affected, the joints are getting spoiled, the blood circulation is getting affected, you are putting the patient on whatever treatment you have so far, and yet the disease is just getting the better of you. That's when you would do a stem cell. And a stem cell therapy would mean that the attempt is to stop going it further. Now, your body's immunity still tends to remain prone to other infections. Your immunity still remains low. You might be better off, you will be possibly able to stall the disease. But mind you, the very first year of stem cell therapy is so critical because the mortality rate, the morbidity rate, the increased sickness rate is highest in the first year. If you cross the first year, then you are better off. So it's like living in a bubble for 1 year after stem cell. If you manage to do that, I am talking about the original stem cell protocols which are laid down in the United States. I'm not talking about the other modified protocols that we are trying to adopt yet. Those are being tried on a compassionate basis. The evidence is based for the ASTIS trial, the Scott trial. These have been proven to save lives, but only after 1 year has passed. If you cross the first critical year after stem cell transplant, then you can hope for a good future. But that 1 year, there is a very high risk of infections and even mortality. So you need to be careful. Don't think stem cell is a bed of roses. It's good. It's very good. It's good to save lives. You should know when to do it and you should know exactly what precautions to take before and after.
Understood, doctor. Uh, Doctor, scleroderma is a gender biased disease. 80% it involves women, and they are all in the childbearing age mainly. So, what do you think? Is pregnancy safe? And if yes, then what steps are required?
Excellent question. In fact, I have been, ironically, apart from our scleroderma group meeting where I spoke about sexual dysfunction in scleroderma, I landed up being asked to talk about pregnancy in scleroderma in our national conference. And so this is something which really intrigues. All rheumatic diseases tend to have pregnancy related complications in most cases if they are connective tissue diseases. Arthritis, rheumatoid arthritis can possibly be milder in 60% of cases because of pregnancy. But all the connective tissue diseases, whether it is lupus or whatever, are really very, very fragile diseases during pregnancy. However, the data on scleroderma in pregnancy is interesting. What it talks about is an increased number of miscarriages with in scleroderma women. So that's the first point, that the rate of miscarriages is higher. Now this is much worse in the first 5 years of scleroderma. So if you have a scleroderma which is less than 5 years duration, your chances of having pregnancy complications are much higher. Now complications for the baby are of course miscarriage, but for the mother itself is dangerous because she can flare very badly, and you can land up even losing your kidneys. You can land up going into clotting disorders and even lung effusions. You land up in the ICU in bad cases. Now, this is because in the first 5 years the disease is rising like this. And because it's rising, that's the time when the disease activity is maximum. Pregnancy is a lot of load on the body, and hence it doesn't make sense at that point in time to conceive. Now, earlier, these questions didn't arise because scleroderma is usually known to happen in women after the age of 30. And in earlier days, what used to happen was that women, the age of pregnancy and the childbearing age, the children, the fertility, all of that was complete by the age of 30. Now we are talking about later and later marriages as women get more and more educated. Later marriages means later pregnancies, and hence you land up seeing these complications much more often than we did earlier. So, when you want to help a woman go through pregnancy, a complete detailed workup, most important, start with the duration of disease, but then do a detailed workup and see where the disease stands. Is it completely quiet? Can the patient be off all the drugs, which are most of the drugs cannot be used in pregnancy? And so what happens is you need to know that the disease is not going to flare up during the 9 months of pregnancy and 1 year of lactation. During the time that you're going to feed the child, also, you can't give most of the drugs of the systemic sclerosis. And then, in which case, what do you do? So, are you confident enough that this disease has become static and it is not going to now cause a threat to the woman's life, or it's not going to cause a miscarriage, which is going to be repeated? Then you give permission to go ahead, monitor regularly, because what happens is that the abdomen, as it grows larger, it compresses the lungs. The lungs are already compromised in a scleroderma. There is a back pressure on the heart. And so a lot of these women require oxygen support if their lungs are affected to a significant extent. It is not advisable to do any kind of family planning if you have pulmonary artery pressures. If you have pulmonary hypertension, pregnancy is out of the question. Adopt. But if you have lung fibrosis, as long as your lung affection is significantly less than one third of the lung, on pulmonary function test, your forced vital capacity is more than 60-65%. That's when you even think of talking to your rheumatologist that I would like to have my own child. Would I be able to?
Very good insight, doctor. Due to the shortage of time, I'm combining two questions into one. A, if the mother conceives, the first question is, will my child carry the disease? Second, if the child has scleroderma, the mother does not have scleroderma, her question is, will my second child have scleroderma? So, do you have any data which talks about this?
So the interesting part is the fact that scleroderma is a genetic disease, not a hereditary disease. Number one. Number two, it's a genetic variant which happens 1 in 3 lakhs. And hence, you're really talking about a very low number of people getting it. Chances of two family members having scleroderma, really unlikely. And if you do get such patients, publish the case report that I found two sclerodermas in one family. There are some environmental triggers that can happen. We are still identifying triggers in the environment like heavy metal exposure, chemical exposure, and so on. However, definite proof of all the agents is not yet available. So if you get a lot of sclerodermas in one community, you also need to look at one, apart from the intercaste marriages and the genetic variations, need to look at their environment. So this is one part because triggers are known to happen from there. Now, mother to child is really not known. Though, interestingly, I have seen some variants where I have seen that there are two completely different autoimmune diseases in the same family, which means that there is an autoimmune tendency, but not really the same disease. So one has an interstitial lung disease and one has a rheumatoid arthritis. These kind of variations we might see, but to have scleroderma happening from the mother's child is having it, and so the second child will get it, that really doesn't happen at all. Now the interesting part here is the fact that when I was studying the entire topic on pregnancy with scleroderma, I came across a paper where they have found that this can happen after miscarriages when there is an ABO, blood group incompatibility, and some antibodies remain in the mother's blood as a consequence of the miscarriage because of the loss of blood brain barrier. So the placenta hai, placenta miscarriage ho gaya hai, some antibodies are there, and thereafter, many years later, a few women have had autoimmune diseases, and they studied this in scleroderma cases. So this was a very interesting thing that I actually came across. And in fact, that paper quoted that they had found the scleroderma 70 antibody 26 years into the patient's, into the son's blood. So it was transmitted in the next child from the mother. So the mother and the next offspring after the miscarriage had it. Very interesting data. None of it is concrete, but people are still studying it. Take home the message, the fact that mother to son doesn't happen. If one mother to daughter doesn't happen, if one daughter has it, the other daughter will not get it. Those fears can be left aside.
Great. One last very small question, doctor. As soon as you tell the patient you've got scleroderma, they Google, and then, it is, oh, my life is over. So, do you think it is possible to live a normal life with scleroderma?
I have been fighting for patients to lead a near normal life in scleroderma for roughly about 15 years, but I've been collecting the data for the last 11 years. And it is true that I have not been victorious every time, but that hasn't changed my attitude. So, as far as I am concerned, I am constantly on the look to help patients lead a near normal life. Like if you are diabetic, there will be a restriction of eating sweets. Similarly, if you have scleroderma, there will be some restrictions, and you need to help me by cooperating with me to that extent. But my target is that you should be able to go on a holiday with your husband. You should be able to enjoy your children's childhood. You should be able to do whatever you would like to do, provided you allow me to look after you in a particular way, regular tests, regular medications, and some restrictions, like, for example, eating your meals on time and having a gap between your meal and your sleep, sleeping with two pillows rather than one, or a wedge cushion so that your food pipe doesn't hurt your lungs. As long as you can do that for me, I am there with you all the while, because that's the only thing that we need, a partnership and a continual attempt to give scleroderma patients a near normal life.
Great. I think, doctor, you answered the questions very well, and I believe the patient should at least, take this information, read about it, listen to you, right? And I think, yes, they can live a normal life and do whatever they want. Thank you so much, Dr. Kaushik Bhojani, for your time.
Thank you so much, Rashmi. Thank you so much for spending time and asking the questions. Thank you very much. Okay, all the best. Bye bye.
Thank you, Doctor. Bye.